Welcome back to The Explainer, everyone. Today, we're diving into something really fascinating. Atrial septal defects, or ASDs. We're going to get into the nitty-gritty of the human heart, looking at everything from how these defects actually start in the embryo, right up to the super cool, cutting-edge devices we use to fix them today. So, whether you're brushing up on your clinical knowledge or just love learning how the body works, you are in the right. But hey, before we get lost in the anatomical weeds, I want to hit you with a number that really puts this into perspective: 90%. That's right, if an ASD is left completely unmanaged, 90% of patients won't make it past age 60. And while sure, sometimes that's unrelated to the heart, when it is related, cardiac failure is the absolute biggest culprit. We're not just talking about some harmless benign murmur here. These are serious structural issues with massive long-term consequences for how blood flows through the body.
Okay, let's look at our roadmap for today. We're breaking this down into 4 parts. First, the clinical stakes. Second, anatomy and embryology. Third, classifying ASD types. And finally, number 4, modern management and complications.
All right, jumping right into part 1, the clinical stakes. Why unmanaged ASD actually matters.
So, congenital heart disease overall, it has a birth prevalence of about 0.8 to 1.2%. But here's what makes ASDs, especially a type called ostium secundum, so unique. It's their longevity. They're literally the most common congenital heart malformation you'll find in adults over 40. Unlike some of the more severe defects you see in newborns, these patients often live to an advanced age. I mean, we've even seen sporadic survivals well past 70. But, and this is a big but, their life expectancy is absolutely not normal. Even though a lot of patients do fine through their 20s, if we don't intervene, the sheer physical wear and tear of that abnormal blood flow, it eventually catches up with the heart muscle.
And this brilliantly illustrates exactly where ASDs fit into the big picture of congenital heart defects. We're dealing with an acyanotic condition, meaning, good news, the blood stays oxygenated. It falls specifically under left-to-right shunts. You see, because the pressure in the left atrium is naturally way higher than the right, the oxygenated blood just gets shoved backward across the septum into the right side of the heart. The result? A massive volume overload in the right ventricle and the lungs. It's kind of like trying to force a fire hose into a garden sprinkler.
Moving on to Section 2, Anatomy and Embryology, basically how the heart forms in the first place.
To really get this, we have to look at how the atrial septum forms in an embryo. It's honestly like a highly choreographed dance. First up, the septum primum, think of it as the first wall, grows downwards, leaving a gap at the bottom called the foramen primum. Step 2. Before that first gap can completely close, a brand new hole, the foramen secundum, pops open higher up. And right as that happens, a second, thicker wall called the septum secundum starts growing next to it. Finally, step 3. These two walls, the primum and the secundum, they're supposed to fuse together perfectly. They form a solid wall with just a little flap valve that seals up after we're born.
Now, what's really interesting here is how clearly you can see this dance happening. Look at that thin septum primum growing down, and then that thicker, beefier septum secundum coming down right alongside it. They overlap just like sliding doors. The whole point of the setup in the embryo is to let blood completely bypass the uninflated lungs by slipping through the foramen ovale. But there needs to be enough overlapping tissue so that the literal second the baby takes its first breath and the pressure changes, boom, those doors slam shut and fuse. But when they don't, well, that's exactly how we get an ASD.
Which brings us to Section 3, Classifying ASD Types. Let's look at the specific anatomical variants.
By mapping out the atrial septum, we can actually pinpoint the exact geographic spots where this developmental dance goes wrong. Way up high, near the superior vena cava, you've got the superior sinus venosus defect. Down low, the inferior sinus venosus defect. Way down at the bottom near the valves is the primum defect. Tucked away is the super rare coronary sinus defect. And right there, smack dab in the middle of everything, is the secundum atrial septal defect.
Let's pause and actually define ostium secundum so we're all completely on the same page. No clinical jargon here. An ostium secundum is simply a hole right in the middle of the atrial septum, right where that fossa ovalis was supposed to seal shut. And guys, this is by a massive margin, the absolute most common type of atrial septal defect you're going to see.
Just how common is it? It makes up 75% of all ASD cases. We really need to understand this specific type, not just because it's everywhere, but because its demographics are super interesting. For instance, there's a really strong female-to-male ratio of at least 2:1 for ostium secundum. That's wild, especially when other defects like the sinus venosus or primum are basically a 50-50 split. On top of that, 30% of these patients have other issues going on. The most common? Mitral valve prolapse, which shows up in about 20% of cases simply because the septum and that valve develop together in the embryo. Oh, and you'll also frequently see it paired with valvular pulmonary stenosis.
So why exactly does an ostium secundum happen in the first place? Basically, there are three distinct ways this embryological process can fail and leave that central hole. First, the valve of the foramen ovale might just be too short. It literally can't reach far enough to cover the gap. Second, you could have excessive resorption of the septum primum. Basically, the body accidentally deletes too much of the wall it just built. Or third, deficient growth of the septum secundum, meaning that second sliding door we talked about earlier, it just never grew down far enough to create a proper seal.
All right, let's move into the home stretch with Section 4, Modern Management and Complications, how we actually fix this thing.
Let's move to this next one and see how this builds into real-world medicine. It's honestly stunning. On one side, you can see a lineup of these metallic mesh umbrellas. These are the physical occluders. And on the other side, that's a cocoon septal occluder actually deployed inside a patient on clinical imaging. The coolest part is the doctors can literally watch these devices deploy in real time using transesophageal echocardiography, or TEE, and fluoroscopy. They do this to make sure the device sits perfectly flat against the walls of the septum, which instantly plugs that leak and stops the left or right shunt.
The modern era of treatment, really from the 2010s up to today, has totally revolutionized how we handle this. We've largely moved away from open-heart surgery for secondum defects. Today, the goals are super clear. We want low-profile delivery systems that can just be snaked up through the veins using a catheter. We want lower risks of erosion, and we want materials with amazing biocompatibility so the body's own tissue just naturally grows right over them. Right now, the absolute workhorses in the cath lab are devices like the Amplatzer septal occluder, the Gore cardioform, and devices like Lefertech, LifeTech, and the Cocoon, which are hugely popular in places like India. So the crucial point we need to make here is that while these devices feel like magic, they aren't totally without risk. If we look objectively at the data, the complications break down pretty clearly. Major issues like device embolization, which is when the device actually breaks loose, happen in about 0.5 to 1% of cases. Cardiac erosion or perforation, super rare, we're talking 0.1 to 0.3%. Minor complications are a little more common, like leaving a tiny residual shunt in 1 to 5% of people, or temporary atrial arrhythmias in 2 to 7% as the heart sort of gets used to its new roommate. And as for late complications, less than 1% of patients might discover they have a nickel allergy to the metal frame itself.
But actually, we need to contrast these slick catheter devices with what happens when a patient has a different kind of ASD. If someone has a sinus venosus defect, you can't just pop a plug in it. No way. These absolutely require open surgery using a patch made from the patient's own tissue. Why? Because in a crazy 90% of sinus venosus cases, the veins bringing blood back from the lungs are literally plumbed into the wrong chamber. So the surgeon has to physically patch the hole and reroute those rogue veins back to the left atrium at the same time. It's a much bigger deal. The contrast between a major open-heart surgery and these elegant, low-profile little catheter devices is just mind-blowing. It really makes you wonder where this entire field is heading next. I mean, with non-stop improvements in biocompatibility, and they're even working on bioresorbable frames that just melt away over time, how far will structural heart interventions go to completely erase the traces of congenital defects? Are we going to see a day where we leave absolutely zero metal behind in the heart? It's a fascinating thought to end on, right? A huge testament to the leaps in cardiovascular medicine. Thank you so much for joining me on this explainer, and as always, keep learning.